At some point in time, hopefully you'll get to a point where a patient is on good medical therapy. They're a bit of all the previous things I've talked about. They're sacubitril/valsartan or ACE inhibitor, they're beta blocker, maybe the mineralocorticoid receptor antagonist, maybe or maybe not the loop diuretic. This is where you need to think, have I done all I can do for my patient? Is there more we need to do? And this is where the role for things like cardiac device therapies come in. Somewhere between 3 and 6 months you need to start thinking about this in patients whose ejection fraction is less than 35%. My tendency is, if they've had an ischemic etiology for their heart failure, to bring that a bit forward unless there's been an acute infarct as the cause of their heart failure. And you can probably delay things a bit longer with a non-ischemic etiology, with the expectation that maybe out to 6 months you may see continual recovery with medical therapy. But at some point in that 3 to 6 month spectrum, if they still have an ejection fraction less than 35%, a device therapy needs to be considered. The first really important point to think about in this device therapy space is, what do patients with heart failure die of? Most people are a bit surprised to learn that with MYHA class 2 patients, the most common cause of death actually is sudden cardiac death. That's an arrhythmic death. And I think that gets missed a bit. People think that this is something that happens to patients with advanced MYHA class 3 and 4. It really is class 2 patients who drop dead of it. And that's simply because the MYHA class 3 and 4 patients die of heart failure before their sudden cardiac death kills them. It's not because they don't get sudden cardiac death, but they've got other things to kill them as well. But you're doing your patient a disservice if you don't stop them dropping dead from their sudden cardiac death when it's imminently preventable. This is a space where implantable cardiac defibrillators come in. Proven therapy to highly effective in reducing risk of dying of an arrhythmic death in patients with an ejection fraction less than 35%, and with MYHA class 2 or 3 symptoms, 1, 2 or 3 symptoms. MYHA class 4 patients are probably too advanced. Defibrillator therapy is not for everybody, particularly the elderly with multiple comorbidities. The sudden cardiac death may be a good way to die, so to speak. Therefore, you may not consider it in that space. But certainly anyone younger with an otherwise good quality of life expectancy of more than 2 years, undoubtedly they should have an implantable defibrillator. Defibrillators, unfortunately, don't make anyone feel better. They're an insurance policy to stop patients dropping dead. I tell my patients that. But patients who have grandkids that want to see grow up, children that want to see grow up, it's a really valuable tool and something that's worth raising for them. That's what people want. They want to see their grandkids grow up. When I said that ICDs only stop people dying, the important therapy to actually give people a better quality of life is cardiac resynchronization therapy, or CRT, or biventricular pacing. That's a concept of putting in a left ventricular lead to improve the synchronicity of cardiac contraction, so that both walls of the heart squeeze simultaneously and improve the efficiency of cardiac output. These devices have been proven to be highly effective in both reducing mortality and, more importantly for the patient, reducing morbidity. They improve their quality of life, improve their exercise tolerance, and markedly reduce by 30% or more their risk of rehospitalisation due to heart failure decompensation. These devices are indicated once again in patients with an ejection fraction less than 35% who've got a broad QRS. That being clearly cut if more than 150 milliseconds, but in selected cases, the ones that QRS are greater than 120 milliseconds, it also has value. In recent years, these devices have been able to add additional functions. These devices are constantly inside the patient, constantly monitoring their cardiac rhythm and other features as well. With that, a whole suite of tools have been developed which enable us to actually assess the status of their heart failure. This gives us a dynamic monitoring of the patient's overall condition. Like in diabetes, where you can monitor their glucose on a many times a day basis, this is perhaps one step better. It can continuously monitor what's going on with their heart and give us trends and clues to say that they're beginning to decompensate. The most primitive technology in the space was called impedance monitoring. It looked at the amount of fluid in the lungs as a marker of developing pulmonary edema. Newer devices have added in additional technologies such as measures of patient activity, measures of patient heart rate variability, measures of resting heart rate, patient posture, and even heart sounds can be incorporated in newest ones. When these features are all amalgamated together, they give a very sensitive means of detecting the potential heart failure decompensation before it happens. Long-standing dangers of primitive tools like weighing a patient is they pick things up too late. The reality is that whilst overall body water influences risk of hospitalisation, often where the water is makes more of a difference. Water in lungs is different to water in abdomen, and that no matter weighing of scales is going to detect that. As a heart failure specialist, I'm very excited to see the development of these technologies in a variety of ways to enable me to detect before symptoms develop, before even the most subtle of features develop and stop the heart failure hospitalisation and reduce what was 30% risk of rehospitalisation at 90 days markedly. Some technologies have shown reductions of up to 50% risk of rehospitalisation, which is hard to ignore in terms of quality of life for these patients.